Good evening, good morning, people of YouTube. Health workers are in demand now more than ever, with no exception to physiotherapists, and especially in COVID wards. But a lot of people till this day still beg the question, how in the world can physiotherapists assist with COVID? Well. The scope of physiotherapy is incredibly diverse. Cardiopulmonary treatment, in other words, the treatment of anything involving the lungs or the heart, is one of them. So anything ranging from trauma to heart surgery to cystic fibrosis to pneumonia is within our scope to treat. And the list goes on. So, firstly, within the ICU or intensive care unit, we do a thorough analysis of the patient by looking at their medication, consciousness, vital signs, blood results, and an analysis of their arterial blood gas, or ABGs. We then further assess the chest through observation, auscultation, analyzing chest x-rays, looking at the expansion of their thoracic cage, and judging the strength of their cough. We are then expected to manage the airway of the patient, making sure they're able to breathe freely through a variety of chest and airway clearance techniques. And this is often facilitated through suctioning if the patient is on ventilation. We also assist with weaning the patients off ventilation by gradually improving their oxygenation over time so that they can receive less and less support through the machine, although doctors are usually responsible for this. From here, oxygen management and monitoring is still very important, and we have a role in assisting with which oxygen therapy the patient should use going further. Many of the patients with COVID present with significant breathlessness and fatigue. So when we're talking about chest physiotherapy for these types of patients, we're really talking about the huge role that we have in education about changes in body position and ways for them to manage their breathlessness through positions of relaxation and also controlled diaphragmatic breathing. If a patient has secretion retention or productive cough, we then use a variety of manual techniques to help loosen and clear the chest through percussions, vibrations of the chest wall, and shaking. This is also facilitated through putting the patient in specific positions to enhance the drainage of that specific lung segment that we're targeting. This is called postural drainage. Airway humidification is also incredibly important at this point, as it can help assist the clearance of secretions. So this is usually done through nebulization with saline or a bronchodilator like salbutamol to help control bronchospasm. Another consistently effective technique that we like to teach our patients is called the active cycle of breathing, or ACBT. Here we teach shoulder girdle relaxation exercises and emphasize the importance of breathing control through the diaphragm. Breathless patients often splint their chest wall and breathe through the apical or the upper segments of their lungs, which don't allow for proper oxygenation as it would if they had to breathe through the lower or basal segments of the lungs. This is why we emphasize basal breathing through thoracic expansion exercises in the active cycle of breathing technique. Then to end it off, we use a forced expiratory technique, or what we like to call a huff, to help facilitate the clearance of secretions at the end of the cycle. ACBT is very powerful because it's all self-performed techniques that patients don't need a therapist to do. Improving self-efficacy is and should always be one of our top priorities as physiotherapists. So moving on, thoracic expansion involves breathing in, or inspiration, but we haven't talked much about expiration. We're in fact trained to perform expiratory muscle training and rehabilitation through strength training. Something as simple as blowing up a balloon can be used in a hospital setting. This provides resistance to expiration and allows our internal intercostal muscles and abdominal muscles to become stronger. But usually this isn't indicated for those with COVID, but rather patients who have obstructive lung diseases. Instead, we use positive expiratory pressure, or PEP, devices to assist with airway clearance and to help with oxygenation within the lungs. You can make one of these PEP devices using a bottle, and this is what we call bottle or bubble PEP. Using a water bottle filled with about 10 centimeters of water, and what we like to use is a suction tube within a hospital setting, no more than 8 millimeters in diameter. It's very interesting. The vibrations help to loosen secretions, while at the same time breathing against positive expiratory forces help to expand airways and improve optimal functional residual capacity within the lungs. Alright, so let's talk more about prone positioning. Essentially, it's used for patients who are hypoxemic or have a low blood oxygen level. So this is usually our primary treatment for those who have acute respiratory distress syndrome, or ARDS. But why do we do it? It helps through improving the ventilation and perfusion of the lungs with the assistance of gravity. We can allow overall gas exchange and oxygenation to be improved by utilizing more of the posterior or the back lung segments as opposed to the anterior or front lung segments. This concept is called VQ matching, but it isn't only used in prone, but in fact all positions to allow for proper oxygenation of specific lung segments that you want to target. Ideally, the most effective position that allows for the most efficient oxygenation of all lung segments is pretty much sitting or standing. So this brings me to my last topic, mobilization. Our end goal is to provide rehabilitative treatment to improve exercise tolerance through activity and mobilization. When someone is standing, walking, or running, their lungs are already in an efficient position to allow for proper ventilation and perfusion. When one exercises, their breathing rate increases, which then again allows for even better oxygenation of the lung segments and also mobilization of any secretions that they may be retaining. At the same time, we are improving exercise tolerance through cardiovascular activity, essentially killing like 3, 4, or 5 birds with one stone. It's important to note that we treat each patient individually, and each treatment session must be tailored to that patient's specific needs. There's no cookie cutter or one-size-fits-all approach, especially when it comes to chest physiotherapy. But if you weren't aware that there are numerous physical therapy techniques that can be used to help assist with chest complications, well, now you do. And that's only the tip of the iceberg. If you have any tips, questions, or ideas for future content, please do not hesitate to let me know. I hope your coffee is strong and your cough even stronger. I don't know. Thank you for watching. My name is Bradley Cato, and goodbye.